subscribe now and press the bell icon. Never miss an update.
Hello and welcome to Health Life at Seniors Today. This is Pradyuman Maheshwari and wish you a very good evening today. And we are delighted to have here with us a very senior doctor, Dr. Arun Kumar Goel. And we've invited him to speak about minimally invasive surgery techniques for cancer. Before I invite him to speak, I'll introduce him. Dr. Goel is Chairman, Surgical Oncology at the Andromedia Cancer Hospital in Sonipat, which is of Delhi. And it is a specialized cancer hospital treating patients from Delhi and regions of Haryana and Punjab and of course everywhere else. It's really heartening to note that cancer care facilities have now gone beyond the big cities, and doctors like Dr. Goel and others are setting up hospitals and ensuring that the reach of cancer care is available everywhere. Dr. Goel is, as I mentioned, one of the top surgical oncologists of Northern India with more than 35 years of surgical experience. He is an alumnus from AIIMS in New Delhi, and he received his surgical oncology training at the Dr. B.R. Ambedkar Institute at the Rotary Cancer Hospital at AIIMS. He has been in practice for more than 25 years and has been associated with some of the leading oncology hospitals in Delhi and the NCR. Prior to joining Andromedia, he was Senior Director at Surgical Oncology at the Max Superspecialty Hospital in Delhi NCR. He has been associated with the Northern Railway Central Hospital as a visiting consultant in surgical oncology from 2005 till date. And he has multiple areas of surgical interest in surgical oncology, including breast oncology, GI, gastrointestinal oncology, gynecological oncology, and has been performing complex surgical procedures for nearly 3 decades with highly successful outcomes. He's also trained in the field of minimally invasive as well as robotic surgery for cancers. He's involved in academics and research from his days at AIIMS. He has more than 70 publications in various national and international journals. He has contributed chapters in textbooks of surgery and oncology, and he's been a reviewer for many prestigious oncology journals. He's a founding member of the Oncology Forum of Delhi and NCR, and he's also a life member of multiple national and international professional organizations in the field of oncology. Today, he was at the hospital and he has come in early home to be with us and to share his knowledge and insights. We were discussing before the session started as to why have we decided to look at a session on minimally invasive techniques, because this is, as he mentioned, is a subject that is there for the medical specialists. And then I mentioned to him that we've had a session on robotic surgery also in the past, and we felt that a lot of people are confronted with jargon such as minimally invasive techniques, and they wonder what minimally invasive techniques are, and how is it that earlier in the good old days there were invasive techniques used, and why is it that minimally invasive techniques are used. So we requested Dr. Goel to speak with us and enlighten us with his with a presentation that he has readied. Even as he has his presentation ready, I would inform you and to all the people, 124 people who are there here right now, and a lot of people are watching us on YouTube. Please put in your questions on the chat window, okay? And you hear doctor first, and then put in your questions. Put in your questions under meeting group chat, and we will address it to Dr. Goel after this. Just a word that this is a session which is advisory in nature. So in case you have any specific requirements, please consult your medical practitioner in your city, in your region. Of course, you can also connect with Dr. Goel at his clinic in Sonipat, and I'm sure he will be available for a second opinion if required. But do remember, this is advisory in nature and not the definite. It is a definite word, but it is advisory in nature. So you must consult a doctor always. And this session is being recorded, and a recording of this will be available as always on the Seniors Today website on Monday evening. Over to you, Dr. Goel, and welcome to our forum.
Thank you, Pradhuman. First and foremost, I must say it is very heartening to see the number of attendees already who have joined the session. And I must say this was a gift from COVID. We have also started doing webinars in the field of cancer from COVID time, and that has continued till now, but we do it once a month or so. And the attendance definitely is always about 150 to 200 people join, while physical conferences, it's very difficult to get people to join. So it is an honor to be part of this session held today at Seniors Live, and I would like to thank you to give me this opportunity. Now, my introduction is already there. What I can say is that with the era that I started my surgical training to now, I have seen all the transitions in the field of surgery. So when I was training in general surgery at AIIMS, that was the time when it was only open surgery. Then towards the end of my general surgery training, laparoscopic surgery got introduced. And initially it was basically for removal of the gallbladder when cholecystectomy became a common procedure. When I was doing my surgical oncology training at Rotary Cancer Hospital, that was the time when people used to say that laparoscopic surgery or minimally invasive surgery does not have a role in cancer treatment because cancer surgery is too complex and laparoscopic or minimally invasive approaches will not be able to manage. However, we have seen a lot of technical advances which have now allowed us to do almost all variety of minimally cancer surgeries through minimally invasive approach. And another significant advance, which Pradhuman also mentioned, is robotic surgery, and it is basically a type of minimally invasive surgery. So now I'll start with my presentation. So what I would like to say is that the presentation is only going to give an overview of this field, introduction to the broad concepts, and I'm not going to go into any technical details or specific applications for specific cancers. However, it is a question answer part which I would be very excited to sort of discuss any specific issues or questions that are there. Starting with the from the foundation that cancer, we all know, is a common disease and the burden of cancer is increasing. And say when we have a group of seniors who are there, so it is, I think, a broadly, widely known fact that the cancer incidence or risk increases with increasing age. And so it is particularly after the age of 40 that the number of cancers occurring rises significantly. 50s and 60s are usually the peak age groups for a lot of cancers. Some cancers occur slightly at a later age, like prostate cancer, which may be much higher in 70s. But definitely, seniors face a bulk of the cancer burden. Broadly, when we talk of cancer treatment, there are three pillars, we can say. It is possible to subdivide or define some finer details, but broadly, there are three pillars. So we have surgery, we have radiotherapy, and we have chemotherapy. And most of the cancers, like as of today, they generally need some combination of treatments. So it is sometimes surgery alone, sometimes radiation alone, sometimes chemotherapy alone, but most of the patients would need a combination, either surgery or radiation, surgery or chemo, chemo or radiation. One thing we need to just broadly understand is that what we talk about surgery and radiation, we call them local treatments because they are applied to a specific given area of the body. And chemotherapy is called as a systemic treatment because drugs, whether they are taken by mouth, they are given IV and all, they are generally going to the all of the body. But there are certain specific situations where chemotherapy may be used in a regional or localized manner. So when we talk of surgery for cancer, so one thing which we need to understand is how is surgery for cancer different from non-cancer surgery. So let us take the example of breast. So normally there may be a lump in the breast which is non-cancerous, benign. People call it fibroadenoma or fibroid of the breast. So if surgery is to be done for that, there is a simple procedure. You give a small cut, go to the lump, remove the lump, close the incision, and that's it. But when we are talking about cancer, the procedure becomes much more complex and detailed. So it means removal of the cancer. So if we say this is a cancer, then removal of that cancer would also mean we have to remove tissue around this cancer. So here it is important to realize that when we say we have to remove area around the cancer normal tissue, then how do we do it? So normally when we do what we call as a traditional or open surgery, so all cancers, we can feel them as hard structures compared to the normal body tissue. So if I feel that this is the hard area, and then I may go 1 centimeter or 1.5 centimeters or 2 centimeters beyond, depending upon the specific situation. So that becomes the margin of normal tissue around the cancer. And in addition to this removal of the normal tissue, we also have something called as lymph nodes. I think you must all be aware lymph nodes. So our lymph nodes are there in all parts of the body, and lymph nodes are part of our immune defense system, but they are also relevant because cancers can spread to the lymph nodes. So for a lot of cancers, we also have to address the lymph nodes for the surgery. So if breast cancer surgery, it is removal of the cancer, it may be, so in some cases, removal of the whole breast, but as of today, say partial breast surgery, at the same time, we do surgery for the lymph nodes in the axilla. So similarly, if there is something in the mouth, we treat lymph nodes in the neck. If there is something in the legs, then we can treat lymph nodes in the groin. Similarly, if something in the abdomen, there are lymph nodes in the abdomen which have to be handled. Now, after we have done the removal part, then at the end of the removal, what is required is that we have to reconstruct the tissue. Because in cancer, we are removing a large area of tissue often. So in lot of cases, we need to do some sort of plastic surgery or reconstruction to close the wound, to establish the structure, to maintain the function, to maintain the features or what we say aesthetic appearances. In addition to this, there are additional things which are important for cancer. One is to reduce the blood loss, because it has been known for quite some time that if you need to give blood transfusion, so it has a immunosuppressive effect on the body. So progressively, if more blood loss is there, more blood transfusion, then more immunosuppression, which can negatively affect cancer outcomes also. In addition to this, we also have to focus on early recovery. This is particularly important because a lot of cancer patients need to have other treatments. So if a patient recovers, say within 2 or 3 weeks, that next line of treatment could be started after say 3 or 4 weeks. But if the recovery itself is going to take 6 weeks, then the patient additional treatment will get delayed. Now, coming to minimally invasive cancer surgery. So what is minimally invasive cancer surgery and does it have a role in cancer treatment? So here we have an image of a OT setup, which is showing, say, a patient having laparoscopic surgery. That is surgery for the abdomen. And we can here see a tower which shows different instruments which are used, which is a camera control unit, monitor, insufflator, and then a diathermy irrigation suction unit. We can see some instruments here and a trolley to have some open instruments which are also required as a small part of the surgery. So cancer surgery, as I had said previously, there was a time when we used to say that laparoscopy or minimally invasive surgery does not have a role. But today we can say that definitely minimally invasive surgery has a proven established role. But what is important to understand is that it cannot be blindly used for each and every cancer case. We have to choose the cases very selectively, because what happens is sometimes the cancer becomes bulky or advanced. Then minimally invasive surgery is not a good approach. So proper selection of cases is important. Whatever precautions are required for open surgery in terms of, say, accurate diagnosis, staging of the cancer, where all it has spread, that is also important. Then the training of the surgeon is very critical, that the surgeon who's doing minimally invasive surgery has to be specifically trained in this, because doing open surgery does not make you an expert in minimally invasive surgery. It is a totally separate surgical approach which has to be learned properly. And we say that there is a learning curve, in the sense that every surgeon would say take 20, 30, 40 surgeries of to become comfortable with minimally invasive surgery. So each surgeon should start his journey under supervision, gradually progress, and when he becomes an expert, then only do these things independently. So broadly, what are the approaches? There are like what we call traditionally laparoscopic and thoracoscopic approaches. There is this category of robotic surgery, and then there is this category called endoscopic surgery. So endoscopic surgery is a minimally invasive surgery approach, but not very commonly used. When we are talking of laparoscopic and thoracoscopic surgery, we, I think, need to realize that the both laparoscopic means for the abdomen and thoracoscopic means for the thorax. Both these areas are what we call natural body cavities. So there is a cavity within the body, and in these cavities, we can put in insufflate air. So air, or generally what we use actually is a carbon dioxide gas. So there is a lot of space there in these areas where we can work, and that makes it comfortable or convenient for the surgeon using laparoscopic instruments. So here we can see this is basically a robotic setup. So here we have the patient. Here we have this instrument, which is basically 4 robotic arms are there, numbered 1, 2, 3, 4. Each of them has, one of them has a telescope, and 3 of them would have instruments. Then there are the monitors for the people in the OT, but these monitors are not for the surgeon. Surgeon works at a separate console. And then this image shows basically ways to do nodes, natural orifice, or endoscopic surgery. So it can be done through the mouth, where a upper GI endoscope is used. It can be done through the vagina in the lady, where you can enter the abdominal cavity from the vagina. And then the third category is through the colonoscope. So these are minimally invasive or endoscopic minimally invasive surgeries. So when we talk of laparoscopic surgery, it is also known as keyhole surgery, because keyhole surgery is like you have a small opening. And this is true of all minimally invasive surgeries. So normally when we do conventional surgery, we generally make big cuts or big openings. So if we go into the abdomen, then we may have a cut which is about 6 inches, 8 inches, 10 inches, and sometimes we may start from top to bottom of the abdomen to be able to work in different parts of the abdomen, because in cancer surgery, sometimes we have to work in all areas of the abdomen. So you sometimes need very large incisions. So what is the problem with large incisions? So the problem which happens with large incisions is that one patient has pain after surgery. So normally there are a lot of ways to control this pain, but definitely it is not zero pain, and the medicines for pain control have to be given on a very regular interval. So now in contrast, when we do minimally invasive surgery, what happens is you put in small sort of instruments. We can see these instruments, they are about 5 millimeters in diameter, and they are put through small trocars. So normally those trocars are about 5 mm, but there are certain instruments which may be 10 or 11 mm. So we have larger trocars of 10 to 12 mm. So normally we make multiple small incisions. So it may be 3, 4, 5, 6, depending upon the complexity of surgery. But these are all small. Usually none of them would be larger than about 13 or 14 millimeters. And they're all separated from each other. So because the incisions are small, patient does not have that much of pain. And because we are having these long instruments, so from a given point, we may go upwards and work in the upper part. We may go downwards, work in the lower part. So from single entry point, we may be able to approach different parts of the abdomen. So generally, one of the most important components is a viewing system, which needs a telescope with a camera control unit and a monitor. And this technology has improved, starting from basic display to high definition display. And now we have what is called as a 4K system. And I think we are all aware of the terminology of high definition and 4K from our television systems also. So as of today, most centers which do minimally invasive surgery for cancer, they use a 4K system because it gives a very good quality image. Then we have lot of instruments for holding, cutting, suturing. Then we have something called energy sources. So we can see one here, we can see one here. So these energy sources allow us to control bleeding or allow us to cut without bleeding. So in addition to this, we also have things like stapler clips. So we can see one sort of a clip here, which is called as a hemlock clip. So these are also used to control bleeding sources. So it is a combination of all these technologies. In addition to this, we also have a suction irrigation system. So this technology which allow us to do these surgeries comfortably without hurting or damaging the tissues too much, but at the same time achieving the end results. What we need to realize is that while in open surgery, the surgeon can feel with his hand where is the cancer and where is the normal tissue. But in minimally invasive surgery, that what we call the tactile sensation is lost. So here, once the tactile sensation is lost, so we have to plan the extent of surgery firstly based on imaging. So CT scan, MRI, PET CT. In addition to this, there is something also called as an intraoperative ultrasound. So there is a dedicated ultrasound which is used during surgery, so we can use an intraoperative ultrasound to identify where the cancer ends, where the normal tissue begins, and how much of normal tissue we have to take. So a lot of these technological supports are important for doing high quality cancer surgery in a minimally invasive manner. What are the benefits? So we have few small cuts compared to a single large cut. Pain is reduced. The skin scars are much smaller and often invisible. They can sometimes be made in a hidden location also. So cosmetically, the patient, they may not be visible to anybody, even when the patient is, say, wearing swimming dress and all. Blood loss is also reduced because we have a procedure in which we are doing the surgery through fine cuts and with good energy sources. So because of these, the patients may have faster recovery, early discharge from hospital, early return to work, or start of additional treatment. But there are certain disadvantages. One, because the complex surgeries through a minimally invasive approach may often take a longer operating time. A surgery which I may do, say, in 1 hour in an open procedure may take 2 or 2.5 hours in a minimally invasive approach. And we have to realize that cancer surgeries are often long and complex. So for very long and complex surgeries, they may be very tiresome for the surgeon also. And as I had already mentioned, learning takes special effort and time. And a surgeon should be trained properly before he attempts these surgeries on his own. Not all cases can be operated. Special equipments are required for the setup and they lead to additional cost. So as of today, if we are talking of a 4K system with all the accessories, the hospital would need to spend minimally about 80-90 lakhs. And if we were to add an intraoperative ultrasound, the total cost may go upwards of 2 CR. Another thing which we have to realize is that if problems occur, then the last resort in case of a problem is conversion to open surgery. So whoever is doing a minimally invasive surgery has to be very comfortable in doing the same procedure by open approach also. So in robotic surgery, there are certain benefits over laparoscopic or thoracoscopic surgery because the robotic arms allow very complex movements. Magnification is much more in robotic system. Vision is 3D vision is there. It's stereoscopic system. The surgeon is also very comfortable because he is sitting on a robotic console. He can stand and maybe take a very short break also for the washroom and all. Suturing becomes easy because of the robotic arms. And to an extent, it is slightly easier to learn compared to laparoscopic or thoracoscopic surgery. The disadvantages are that the robotic equipment is very, very costly. Till 1 or 2 years ago, the hospitals had to spend 15 crores or more to acquire robotic equipment. Now we have 2 or 3 options and the costs are coming down slightly, but it takes some time for them to come down significantly. You need a specialized team. All team members have to be trained in robotic surgery. Complex equipment may sometimes malfunction during surgery. Again, not all cases are suitable. And if problems here again, you need to either convert to laparoscopic or open surgery. So common applications for minimally invasive surgery, abdomen, again, so abdomen, large intestine, colon and rectum are commonly operated by laparoscopic approach. Gynecological cancer surgery, we use this surgery for endometrium. For cervix, some cases. So there was a time when a lot of cancer cervix was operated by minimally invasive approach. Then there was some data that the outcomes are not as good for cervix with minimally invasive approach. So nowadays for cervix, only very, very early cervical cancer is operated by minimally invasive approach. Then we can have surgery for cancers of prostate, kidney, urinary bladder that can be done easily by minimally invasive approach. In thorax, we can do surgery for esophagus, lung, mediastinal tumors and all. Head and neck again is an area where minimally invasive surgery is not very commonly used, but some patients insist, particularly because otherwise the scars in the neck, some patients are very, very conscious about scars. So there are possibilities that you can do an approach where the incision can be placed either in the armpit or towards the back of the neck under the hairline and all. Then we have more complex surgeries like surgery of the stomach, pancreas, liver and all, which can also be done by minimally invasive approach. So overall, this is where I would like to just stop the part of the formal presentation and then would prefer a discussion. So maybe if Pradyuman, you have some questions or we have audience
I
questions,
have
then
got the questions. Quite a few questions have come in.
yeah.
One question at least 4 or 5 people have asked is, and you did indicate about the costs a bit, but is minimally invasive uh, surgery in terms of costs? How does it compare with the open surgery?
If I think you must be aware, when it comes to robotic surgery, say compared to a given open surgery, there is an minimal additional expense of about 1.25 to 1.5 lakh rupees. But if robotic staplers are used, this cost may go up a little more. When it comes to minimally invasive like laparoscopic or thoracoscopic surgery, there is no specific benchmark, so it depends upon the hospital policy how much. But lot of hospitals, generally there is a difference between the fees which are charged for open surgery and the fees which are charged for laparoscopic surgery. But there is a flip side to this also. Suppose a patient with an open surgery has to stay for 5 days after surgery, and after minimally invasive surgery, if we can discharge the patient in 4 or 3 days, then some of the extra cost actually gets saved and the total burden on the patient may not increase much.
Right. Thank you, Doctor. We have received quite a few questions, but
Yes.
many of them are not surgery related. They are general oncology. So we'll first raise the surgery questions
Yeah,
first,
okay.
and then we'll look at
Other questions.
other questions. But there's a question which is important, which I would anyway take. This is from Neelu Batra. Dr. Saab, my throat is hurting since long. Throat endoscopy and CT scan of neck are normal. Please advise the cause and remedy for the same.
I think it is very difficult to sort of give a very specific answer. There are a lot of reasons for throat discomfort, which may be related to, say, sinus problems or chronic tonsillitis. And also, I think definitely specific answer would be difficult. Should maybe consult another ENT specialist, get your throat checked again, and sometimes long-term antibiotic therapy or other treatment may be required. If the symptoms are worsening, then you have to be much more aggressive in getting it checked and treated.
In fact, a related question which is there, and I think a lot of people have it in their in mind, and which is why I'm raising it. This is a question raised by Dev Huti, saying, why do we come to know about cancer sometimes at the last stage when the person cannot be saved?
Yeah. So I think here we have to realize the 2 or 3 things. Firstly, cancer is not one disease. Cancer is, let us say, more than 100 different type of diseases. So each cancer behaves differently. Some grow slowly, some grow rapidly, some have a tendency to spread rapidly to other organs, some have a tendency to sort of be in the same area for a longer time. So this depends upon the type of cancer. So in this sense, I could say maybe cancers which are starting, say, in the liver, cancers which are starting in the pancreas, cancers starting in the lung, these often tend to be aggressive and spread to other organs fast. But say in other cancers, when we talk of breast cancer, about 70% of breast cancers are slow growing, about 25% are faster growing, and they may spread. And secondly, what happens is the time period. So often, if we allow time after the first symptoms we have noticed, a period of 2 or 3 months may be quite harmful, and this is something which often I use a puzzle to explain this. Maybe if I can just, if we have a pond with a single flower, the number of flowers doubles every day, and the pond is full in 30 days. When will the pond be half full? So I have seen many times people answer 15 days, but actually the answer is 29 days. So the pond is half full on 29 days and totally full on 30 days. So what we have to realize is when people come to know of any symptoms of cancer, about 25 to 26 days in the journey of a cancer have already passed. So
Right.
often in that phase, a delay of even 1 or 2 months may be very harmful. So patients, I have seen many times, patients with breast lump, they may just say 5 or 6 months ago they noticed, but did not come to the doctor for whatever reason. Patient may have an ulcer on the tongue or on the cheek and has not gone to the doctor. There may be a mole on the skin, they have not gone to the doctor. There may be blood in the urine, they don't go to the doctor. There may be constipation, they don't go to the doctor. So any amount of this delay, that is also one of the reasons. But definitely the behavior of cancer, it is possible that on day one I have a symptom and it is stage 4 on day one. It happens in some cases.
Right. Uh, Doctor, there's a question from Naina Somaya who asks, is it right to do a breast cancer surgery if the patient is over 80 years old?
See, definitely, I don't think age as such should be the criterion to choose that. And we all know we say age is a number. So a person who's 60 or 65 may not be fit for surgery, while a person 80, 85 or 90. So we have done breast cancer surgeries in women who have been above the age of 90 also. So it depends, one, what is the performance status we say? Is the patient mobile? Patient should not be bedridden. Patient's major organ system should be functioning well, and definitely the cancer should be fit for operation. So if the patient, it can be safely done, it should be offered. If the patient cannot have a safe surgery because of multiple medical problems or being bedridden, then we look at non-surgical options.
Right. Doctor, there are quite a few. Uh, you've already answered questions about what are the chances of these ending up in conventional surgery. But another question that I have just got is that in case there's always a doubt about minimally invasive surgeries not being totally successful, should we, is the doctor's call the best thing for this, or should we even recommend to the doctor about minimally invasive, or should we just go ahead with whatever the doctor is advising?
It's not a question of recommending to the doctor, but what I would say is that, see, a doctor may recommend open or minimally invasive surgery for many reasons. One is whether the case is fit or unfit for minimally invasive surgery. Then sometimes whether the surgeon himself is comfortable doing minimally invasive surgery or not. And it is possible that there may be hospitals where complex equipment is not available because it is not a basic minimally invasive surgery equipment which allows you to do cancer surgeries. So you need to have advanced equipment like high resolution optics and good energy sources. And also not every hospital may have them. So there are a lot of things. But what I can say is that in any given situation, if the surgeon is trained in open surgery, the open surgery is the gold standard through against which we match minimally invasive surgery. So the only thing which happens if you have open surgery is that, okay, you may need to spend 2, 3 or 4 more days in recovery. But otherwise, the cancer outcomes are not negatively affected in any way. In fact, you have to be concerned that the cancer outcomes in minimally invasive surgery will be good only in the hands of a trained surgeon and a properly selected case.
Right. Doctor, I'm going to ask you a question. How do you
Yeah.
define a trained surgeon?
See, trained surgeon, basically, as I said, for every surgery, there are, or every field, there are sometimes it may be degree, but when it comes to say a cancer surgery degree, that does not define if you are comfortable with minimally invasive surgery or not. So firstly, it is upon the surgeon to himself know his limits or his expertise. Then patients can definitely ask the surgeon very specific questions. The specific questions may be that for that given case, what is the number of cases he has done, say by open surgery, or the number of cases he has done by a minimally invasive approach. If we can give a reference for one or two patients who have had this sort of a procedure in last few months or so. And so all these patients have the right to ask all these questions, get answers. And if he is not satisfied with these answers, he has a right to seek another opinion and only go for treatment when fully comfortable.
But doctor, while you have said this, is it normal to ask a question like this? Will a patient not hesitate to ask a doctor, this question, because you are already, reposing a lot of faith in the doctor.
Yes.
One looks at a doctor in a different way
No.
always.
So what I would say is that definitely reposing faith is a part of the treatment process. But what I can say is that one patient has a absolute right to ask questions, so there should be no hesitation. And what I would say is when it comes to the question of reposing faith, so you should start reposing your faith after you have satisfied yourself, you have asked all the questions. Once you decide to submit yourself to treatment, that is the time when you absolutely assert your faith. Then is not the time to doubt or have any doubt.
Thank you, doctor. I think you've said it very well. We have a couple of more questions, doctor. We have already
Yeah,
at
sure.
5:40, but there's a question from Asha Jamkar. She asks, an important thing is blood cancer does not require surgery to eradicate it forever. So what should
Yes.
be done to avoid its recurrence?
When it comes to recurrence, see, for all cancers, recurrence basically is some percentage of cancers recur. It depends upon the type of cancer, the stage of cancer, and sometimes it may be about the treatment. So blood cancers, when it comes to blood cancers, they are definitely treated by chemotherapy mostly. There are a few in which radiotherapy may be a part of the treatment. Surgery may be basically sometimes you do a biopsy of a say lymph node to make the diagnosis, or sometimes you place a chemo port for giving chemotherapy. So that may be the only role for surgery. But when it comes to recurrence, I don't think other than completing the treatment of cancer in as advised by the doctor, and then basically after that maintaining a positive attitude, healthy lifestyle, be active. So a positive attitude, sort of healthy lifestyle would give you some benefit. And go for regular checkups so that if there is any recurrence, it should get picked up early. And early detection of recurrence allows you to do a retreatment also. So many blood cancers, when they recur, you can go ahead with, say, bone marrow transplantation, cure them. Then nowadays, we also have the option of something called as CAR T cell therapy in some cases.
Right. Doctor, this is a question that is coming from somebody, but I'll withhold the name given the nature of the question.
Okay.
She says, I have a lump in my breast and got an ultrasound where the doctor has said it's benign and non-cancerous. Should it
Okay.
still be removed or should it be there?
So if the lump is recent onset, if it is increasing in size, or depends upon the age of the person also, whether there is a family history of cancer, whether the ultrasound findings are 100% clear or not. So there are many things which are involved in decision making. So you may take another opinion just to sort of confirm that the advice is proper. Sometimes lumps are large and patients themselves are uncomfortable. So then it is removed not for a medical purpose, but just for the patient's personal comfort or choice.
Right. Doctor, there are a couple of questions that have come in, and I know it's not an answer that you have. Is that why is it that cancer surgery is so expensive, and what can be done to, because there are expenses which go beyond the surgery, and
Mhm.
what can be done to ensure that one gets. And this is a question which one person has asked, because I'm a senior citizen and I do not want to load my children
Okay.
with this burden of expenses.
So one thing I can assure you is that when we talk of expenses of cancer surgery, so cancer surgery is not more expensive than any comparable surgery. So let us say if we do a breast cancer surgery, so the patient may spend 1.5 lakh rupees, or around, maybe it may go up to 2 lakh rupees or so in the normal case. There are some cases where if a reconstruction is being carried out, it may be costly. The surgeries which cost high include surgery of cancer of the esophagus, or surgery what we call as a Whipple surgery, or surgery for liver. So these are very complex surgeries. Patients are often in hospital for a long period of time. So in this case, the cost of total treatment is because of the number of days in the hospital, number of days in the ICU, blood transfusion, costly antibiotics. So there are so many components which go into it, and definitely there are limits to how much a hospital could reduce. And what I know is that as the surgery complexity increases, the reimbursement of the surgeon is never proportionate to the extent of effort. But definitely we need to look at that treatment should be accessible to each and every person. So firstly, for people who have the wherewithal, then health insurance is a very important part, and health insurance should be sufficient in amount, because the Indian health insurance is a fixed in amount. So today having a health insurance of 2 or 3 or 4 lakh rupees is not sufficient. So probably generally at a minimum, and starting at a younger age, you go for a high quantum health insurance, because if you think about increasing the amount after the age of 60, there may be a problem from the insurance companies. Then other than that, definitely depending upon, say, government, this Ayushman Bharat scheme also allows a lot of people to access treatment. Then there are options like you have private hospitals at different levels. Same treatment may be 8 lakh rupees in one hospital, 7 in another, 6 or 5 in another. It may not definitely go below that, but then you have to think about maybe government hospitals which have good treatment capabilities. It takes a little bit of, you have to handle the crowds, but good treatment is available.
Thank you very much, Doctor, for this session, for painstakingly, responding to all the questions. I know a lot of questions have come in which I have not answered. Perhaps there are more questions that I have not
I
answered,
know.
but asked, but they were not surgery related. But what we are doing
Okay.
is we have made a note of those questions, and we will, raise them in the right forum quite surely. And we will take those questions when we'll have more sessions in the field of oncology in future. Thank you very much, Dr. Arun Kumar Goel, for this session. It's so heartening to see that there is amazing care in the field of oncology available across the big cities, and you are catering to areas like Haryana, Punjab, etc. Also, which otherwise people would make a beeline to Mumbai, to Tata Memorial, or to Delhi, to
Yes.
AIIMS, etc. So it's heartening to note that we have the top surgeons and physicians available across the country. Thank you very much, Doctor.
Thank you, Pradhuman. And once again, my thanks to all the people who joined for this session. It's very heartening to see so many there. Thank you.
Doctor, I'm going to take a minute of yours. We have, as you know, we are part of Seniors Today. Our new issue has just come out, last week, earlier this week. And I'm going to request our producer to just play a short video which has the highlights of this issue.
Okay.
And we have, senior doctors also who have written in this issue. One on Crohn's disease, IBD, which is there. A doctor from Breach Candy, Dr. Prasanna Shah, has written this article. And, we have other articles that are also there. So the Seniors Today website has the articles, has the magazine. Yeah, this is the video. So this is the magazine which is there, and it's available free of cost on the website. Once again, while thanking Dr. Arun Kumar Goel and the Andromedia Hospital for facilitating this, we will be back again next Saturday at 5 p.m. with another session of Health Live at Seniors Today. We have a special session on caregiving that's there because that's an important facet, and as Dr. Goel will testify, even with cancer care or with every other major ailment, it is very important. And so we have a special session on caregiving next Saturday. Do join in, and thank you once again to Dr. Goel. Thank you.
Thank you.
Subscribe now and press the bell icon. Never miss an update.